Unfortunately, I could not be here in real life with you, so that's why I recorded my presentation. I'll talk to you about transition from childhood to adulthood for patients with rare genetic syndromes, because that's what I do in daily life, both in Erasmus MC in Rotterdam and in Radboud MC in Nijmegen in the Netherlands. These are my disclosures, and these are the patients that we're talking about. So thanks to excellent pediatric care, patients with rare genetic syndromes reach adulthood more and more often. So their life expectancy has greatly improved. And that's why we need adult care. It used to be non-existent in the old days, but in 2015 I started an outpatient clinic especially for young adults and adults with rare genetic syndromes, because that was what was lacking, and the pediatricians had an urgent need for adult follow-up. So, for example, Prader-Willi syndrome. Here you can see on the left how people with Prader-Willi syndrome used to be. So they used to have severe obesity, poor cognition, poor mobility. And thanks to excellent pediatric care on the right, you see how they are now. So they have become more mobile, their quality of life has improved, they have less obesity. And I think as adult endocrinologists, we really have the responsibility to take over care for these young adults, because most pediatricians, they are obliged or forced to keep those patients with them because there's no adult follow-up. So that's why I started this outpatient clinic in 2015. And here it is in the Erasmus MC Center for Adults with Rare Genetic Syndromes. And these are our activities. We have multidisciplinary patient care. And because this care is unique in the Netherlands, we have different cohorts of patients with rare genetic syndromes who all come to our hospital because they cannot get this multidisciplinary care in any other hospital, which also gives us a lot of possibilities for scientific research. That scientific research often leads to new innovations or new information that we share with our colleagues. This is the multidisciplinary team that we work with. So people with rare genetic syndromes often have a combination of a brain phenotype, let's say intellectual disability, ADHD, autism spectrum disorders, or epilepsy, combined with physical problems like congenital heart defects or hormone problems or other organ problems. So this multidisciplinary approach of taking care both for the body and the mind really works. So that's why we have neuropsychologists, but also physician for intellectual disabilities, dietitian for intellectual disabilities, internists, and the entire outpatient clinic is coordinated by a nurse practitioner. Since 2015, we have helped over 1,300 new patients with over 130 syndromes. And most of the syndromes, although they have some syndrome-specific needs, they all benefit from this multidisciplinary approach. This is just an overview of the syndromes that we are also center of reference for, acknowledged by the Dutch government. And these is just a list of some syndromes that we also see that we are not center of reference for that because it doesn't exist, because the patient numbers are too small. But it's just to give you an overview of what we do daily. Now, the interesting thing is that we take care of the patients and they're happy with that. Their quality of life improves. But we can also learn a lot from them because most of the syndromes are caused by a mutation or a genetic defect in one gene or a couple of genes. So this couple of genes that is affected also tells us a lot about the function of that gene and of the protein that it codes for. So I think our syndrome clinic is a good example of how you can both help people and learn from them at the same time. And it's really kind of pathway medicine because it helps us also to understand how the body usually works. Now, as I said, most patients come from the pediatricians, and the transfer from childhood care to adult care can be really difficult. And this slide is not to compare my patients with cows, of course not, but it's just to show that sometimes you want to go from one place to another and it just doesn't work and you don't succeed. So we focus on transition and to improve it. What can go wrong during transition? There can be a problem in the pediatric department, can be a problem in the patient, him or herself, for example, psychological problems or fear of going to the other side. There can be logistic problems, and there can be problems at the adult department. So there's a bridge between two mountains, let's say, and the problem can be anywhere in between. Now, Kirsten Davids, our nurse practitioner, she did a research project where she looked at over 400 young adults who made the transfer or should have made the transfer to adult care, but a lot of them did not show up. So 25% dropped out, and that's the same as in the literature. Well, Kirsten looked into this cohort, and she looked where did it go wrong. In one of every 3 dropouts, the problem was that there was no letter of referral written by the pediatrician. That's a very clear problem. So if there's no letter of referral to the adult department, the adult doctor does not know that he should invite the patient, and the patient doesn't receive a letter, so nothing happens. So that's a very clear cause. Then another third of the dropouts, there was a letter of referral, but there was no appointment made for the adult department. And another 5%, there was a letter of referral. It was read by the adult department, we could see that in the system, but no appointment was made. Maybe because the secretary forgot or something happened in between. So as you can see, apart from psychological issues or fear of going to the other side, there can also be just easy, simple logistic problems that we can easily tackle. So to tackle these logistic issues, we have a few recommendations. When the pediatrician says you're now ready to go to the adult department, and he sends a letter of referral, he should check afterwards if the appointment at the adult clinic was really received by his patient. Our advice to the adult outpatient clinic is to review and read the pediatrician's letter carefully. Sometimes the letter is read but not well enough, and they miss a small line in the end saying, please give this patient an invitation for your clinic. We recommend that there be a direct communication between the pediatrician and the adult doctor. So not only the formal letter of referral, but also informal communication like an email, or when you see each other in the hospital, say, hey, I referred this patient to you. Could you please check if the letter of referral was, if you received it? So to have like a second checkup or a second backup check to make sure that the letter of referral is really received. And then also very important, the patient and their caregivers should also be aware that sometimes it goes wrong. And I would say, always tell your patient that if within 2 months they have not received an invitation for the adult department, please let me know. So then something did go wrong. Apart from these logistics problems, there can also be a problem in the adult department. I think this slide's really illustrative. What I see in my adult colleagues is that they have a bit of what we call cold water fear. So they're afraid to jump because the water is cold. And what I mean by that is this population of young adults with rare genetic syndromes is a new kind of patient population. So for the adult healthcare providers, it's unknown. They don't know how complex the syndromes are. They don't know how to treat people with intellectual disabilities, which is often the case. So they have a bit of fear to start this type of outpatient clinic. Usually when a doctor sees a patient with a disorder that he doesn't know, he reads the guideline. But for these disorders, there is no guideline. There is no adult guideline because these patients often used to die before reaching adult age. So there are no guidelines for adult patients. So that makes it really complex for the adult healthcare providers to start an outpatient clinic. So what we do, and what my mission is also for the next 20 years, is to make adult guidelines, to make sure that the adult healthcare providers know what to do when they see patients with a certain rare genetic syndrome. And we started with PWS, Prader-Willi syndrome, with an international network with which we studied over 800 patients, which is very much for a rare disorder. And we made all kinds of guidelines and practical recommendations, and some of them were published as PhD thesis. And they really helped my fellow adult endocrinologists to take care of this type of patients. Because the practical recommendations are really practical. Sometimes my colleagues say, I really had your algorithms at my desk when I was seeing this new type of patients. And that really makes me happy, because then I know that thanks to our work, the people with rare genetic syndrome are really getting improved healthcare. So we also made visual overviews for a number of syndromes to show the hormone problems, the organ problems, etc., that are part of the syndrome in adulthood. We made an overview article with pictos showing all the organ and hormone problems that an adult healthcare provider should be aware of. We made websites with information about all kinds of syndromes. So, and it's really helped. So in the end, we now have a small network within the Netherlands covering syndrome care for adults, well, in most places in the Netherlands. So my mission is that nobody should drive more than 3/4 of an hour before getting to a doctor who knows about this syndrome. We're almost there, I think. So this really helps. We're also active within Ithaca in a work group for adults with intellectual disabilities, where we focus on, for example, making guidelines or practical recommendations for certain syndromes, but also what happens when young adults with rare genetic syndromes get older. Do they age prematurely? Do they get older before they are really old? We sometimes see that happening in certain syndromes. So that's a very interesting field as well, to understand why some people with intellectual disabilities or some people with rare genetic syndromes look much older than they really are. Apart from this really medical things that we do, we also care for the parents, because we need the parents, for example, to give the medical care to their child. Of course, when the child lives in an institution, there are also professional caregivers, but lots of the time the patient is at home during the weekends, and the parents are always involved. So 24/7, they're always taking care of their child, even if it does not live with them. They're always communicating with the healthcare institution, etc. So we want to keep the parents fit and healthy and mentally strong and resilient and vital. So we made a parent support program, and we made it together with a group of parents and a lot of doctors and nurses. And it is really made for the situation of parents with, as we call it, a care-intensive child, so complex care child. And that support really helps. It's an app-based real-life support. I can tell you, I could talk for hours about it because I'm really enthusiastic about it, and the parents are as well. But we have no time for that, so I have only 1 minute left. So please scan the QR code to read more about it. You can translate the page. It's in Dutch still, but of course we can translate also this app in other languages. That's not much work. And so if you want to have this kind of support for your patient population or your country, we can also always do that. Well, this is what I wanted to tell you. So transition in this patient population of people with rare genetic syndrome is really challenging because there's a lack of knowledge that is huge. But we have to start somewhere, and that's why we started this outpatient clinic. It's really rewarding. The parents are happy, the patients are a lot of the time very grateful. And well, this was what I wanted to show you. Hope you enjoyed the conference, and yeah, I would say happy to answer any questions, but that's impossible because I'm not live there with you. But you can always send me an email with your questions to the email below. Thank you for listening. These are the patients, or the people, not the patients, but people that I work with. Of course, I could not do this on my own. And thank you for listening. Bye bye.